All right, I'm Karen Kuntz from the University of Minnesota, and I will be moderating. I'm going to start with an announcement. The taxi stand is on 22nd Street, not Avenue, Street. If you go out the back, you take a left and a left. If you go out the front, you take a right and a right. So you get the kind of idea visually where it is. All right. Let me get my notes. So I'm going to present a little bit on the modeling and the uncertainty chapters. And before I start, I'm going to introduce our speakers. We will be hearing from Tom Trigalinos, who's an associate professor of health services policy and practice and director of the Center for Evidence Synthesis in Health at Brown University. And then we'll hear next from, and he'll talk about the evidence chapter, synthesis chapter. The next we'll hear from Murray Krahn, who is a general internist and senior scientist at the University Health Network in Toronto. He's the F. Norman Hughes Chair of Pharmacoeconomics and professor at the University of Toronto. And he will talk about one of the worked examples. And last, we'll hear from Norm Daniels about the ethics chapter. Norm is the Mary B. Saltonstall Professor of Population Ethics and Professor of Ethics and Population Health in the Department of Global Health and Population at the Harvard T.H. Chan School of Public Health. Good? All right. Let me know if I'm not talking into the microphone loud enough. Just wave from the back. Sunglasses on. Is that the transition lenses? Sorry. John's like looking at me with shades on it. All right. So decision models provide a framework for decision making under uncertainty. And it's been used for many, many years as a mode to conduct cost effectiveness analyses. They help structure the analyst's thinking and facilitate the communication of assumptions. And they provide a structural framework for synthesizing data from disparate sources and allow for extrapolations of many forms. The conceptualization phase of the building decision model requires expertise from both modeling and also experts from the field of investigation. So even though in the 1990s models were used quite often for conducting cost-effectiveness analyses, I was guilty of some of those, the original panel devoted little attention to modeling. This was kind of the one primary recommendation that was in the original panel book. Where direct primary or secondary empirical evaluation of effectiveness is not possible, for example, in important subpopulations or in different time frames, the use of modeling to estimate effectiveness is a valid mode of scientific inquiry for CEAs. So now we've kind of expanded on this a little bit into a chapter. So analysts are often faced with situations where modeling can be informative. And since the original panel, we have several country-specific guidelines for conducting CEAs for health technology appraisals, including recommendations that include recommendations for developing models. So we looked at a lot of the guidance that are out there from NICE, from Canada, from Australia. There have also been several publications related to best practices for the development of decision models, and we looked at those publications, one of them being the ISPOR SMDM Task Force on Good Practices in Modeling, something like that. There's a series of 7 papers. So there's the need for decision models come up often related to the idea of needing to extrapolate. So there's a need to extrapolate beyond the time horizon of available data when the time horizon of the cost effectiveness analysis doesn't really match the time horizon of the clinical studies. There's a need to extrapolate often from intermediate or surrogate outcomes to long-term outcomes, such as quality-adjusted life expectancy. There's a need to extrapolate to different population subgroups not observed in studies, for example, maybe older ages or multiple comorbidities, presence of multiple comorbidities. There's a need to extrapolate long-term outcomes associated with diagnostic test strategies, where we often just know sensitivity and specificity from clinical studies, but for cost-effectiveness analysis, want to know longer-term outcomes. And there's a need to often extrapolate strategies that have not been compared in head-to-head comparison. So as Doug mentioned this morning, we need to be able to evaluate all the reasonably available strategies, and they're not always compared head-to-head. Extrapolation across studies is required. So I don't know if this will be confusing the matter or not, but I'm going to attempt. So on the right, you see sort of a hypothetical survival curve that you might see in a study that has a 5-year time horizon. So we can, the difference between the red line and the dotted line to the left of this line, which represents the time horizon of the clinical study, represents the benefit in terms of life years gained. And we can, of course, adjust that for quality-adjusted weights. And if you look at the corresponding graph to the left of the 5-year mark is the underlying hazards that might create that survival difference. And if we make the simple assumption that at the end of the trial, that the patients in the control arm and in the assuming they're alive, that they have no difference in terms of their subsequent prognosis in terms of mortality, we still get quite a big difference if a large portion of the initial cohort was still alive at 5 years. And so by stopping an analysis at the time frame of 5 years, we're sort of missing a large part of the potential effectiveness. The original, and then the other graphs here just show different assumptions. So the original panel kind of said that they recommended doing a sensitivity analysis looking only at the time horizon of the studies that are available and looking at longer term trials without putting emphasis on one or the other. And I think we try to do a little bit more in saying if in the conceptualization phase you decide that lifetime horizon is the right approach, then you should make it a lifetime horizon and only do the short-term analysis if you think it's necessary to clarify. It's as a sensitivity analysis. If you think it would be sort of helpful to the decision maker or the reader to provide that clarification. What's important, though, is to do more of a structural sensitivity analysis on the different ways that you can extrapolate beyond that 5 years. So this was a paper that was mentioned before, Hlatky, Gillian, and Saunders and Owens, that looked at the cost effectiveness of ICDs. And so ICERs is on the y-axis, the incremental cost effectiveness ratio of implantable cardiac defibrillators, and then kind of a time horizon is on 1 to 4 years is shown here, and you can sort of see within 1 to 4 years, quite a big difference in terms of what you would get for the incremental cost effectiveness ratio. And then there are sort of 3 possible scenarios for the lifetime in terms of whether the survival curves converge or parallel or diverge. And so this might be an interesting sensitivity analysis to report, but ultimately the reference case should focus on the time horizon that was decided to be relevant. So some of the key modeling recommendations is that the initial conceptualization of the model should be independent of the data identification phase. That it's important to sort of conceptualize from a theoretical or biological standpoint and not just what data are available, and then it becomes interactive. Full documentation and justification of structural assumptions should be provided. I think that really helps with the transparency discussions that we've had before. The analyst should specify the starting population and whether they're analyzing a cohort or a population, and justify why. I think this gets to a question that was asked this morning by Nick about infectious disease models, and that those tend to be population models, and and have a different, and tend not to be, the cohort model tends not to be as relevant for those types of questions. And lastly, validation of the model should occur throughout the conduct of the CEA. So just a little bit about uncertainty analysis chapter. So the propagation of input uncertainty informs decision uncertainty, and that's what we're most interested in a CEA, is really how it affects the decision. When doing, and this can be done within doing a probabilistic sensitivity analysis, and that it's really important to try to capture the correlations among the parameters, and with recognition given that it's challenging to do this when all of the parameters are estimated independently. Structural uncertainty should be explored, and I'll talk about this a little bit more on the next slide, and that expected value of information analysis should be used to ultimately guide decision making under uncertainty. And that can be decisions of whether to adopt the intervention now or to conduct further studies. So in structural uncertainty, we want to know, for example, we've already talked about this, sort of how to model the effects of an intervention beyond the time horizon of the data, how different states of health and pathways of care are characterized in the model, and try to explore different ways of doing that, how disease progression is modeled over time, again, beyond the follow-up period of study, and there are different assumptions that can be made, and the extent that we can sort of show how that impacts the results. And even judgments about the relevance and appropriateness of different sources of evidence, to the extent that we can look at the impacts of including different types of data in our models. And then lastly, I will end with the notion of sensitivity analysis as opposed to uncertainty analysis. So sensitivity analysis, the typical one-way, two-way threshold analyses, where we vary one or two inputs to examine the behavior of the model outputs, is less valuable for looking at decision uncertainty, and probably most valuable for providing insights about model behavior. And it can also be a useful means for understanding implications of heterogeneity in the base case. So I think I'm done with my 10 minutes and pass it over to Tom.
Hello. I will be terse in my thanksgiving, but not because of lack of gratitude. This is the chapter on evidence synthesis for informing cost-effectiveness analysis. So starting, I say that all of us in the panel subscribe to this principle of total evidence. And by that principle, we mean that maximizing the use of relevant evidence increases the likelihood of good quality decisions, good quality in the sense of the objective implied by the cost-effectiveness analysis. And evidence synthesis is simply about getting the information, identifying the information, structuring the information, and using it to inform the various model parameters that one uses in a CEA analysis, in an analysis model like the models that Karen alluded to. So how does evidence synthesis inform cost-effectiveness analysis parameters? We conceptualize this as a series of two steps, and the description is facilitated by introducing a concept, a construct, what I will call here the evidence synthesis model. The evidence synthesis model describes the relationship between static characteristics and bias-free parameter estimates. Once you have learned that model, you can use it to predict what the value of a specific parameter is in the model, in the context that is implied by the CEA setting. So that conceptualization, I will try to outline, to sketch a bit by using this schematic, which is borrowed from the book. I will hazard an explanation, but it should not satisfy you, and I will ask you to refer to the book. Say that we are interested in informing a cost-effectiveness model with respect to, for example, the treatment effect for a pairwise comparison of interventions. the box, and that we have capital case studies that are relevant to this information. The box on the left tries to represent the evidence base that is pertinent to that treatment effect. And there are several studies, case studies, that are represented by rows, and for each one of the rows we reserve 4 symbols. We have, which are arranged in the columns. We have symbols that try to capture the contexts of the studies, and by that we mean the salient differences between the studies. There's a symbol for the observed study results, and the last 2 columns are symbols for the study estimates, which is what the study analysis finds, and the study estimands, which is what the study would have found had it been perfectly designed, conducted, and analyzed. The difference between what the study finds and what it would have found in its idealized form is summed up in the net effect of biases, of study-specific biases. When we do a cost-effectiveness analysis, we're interested in bias-free estimates. The evidence synthesis model, and those estimates of bias are unknowable, and they have to be explicitly quantitated by the analyst. The evidence synthesis model takes all those things into account, and it tries to describe how the bias-free estimates behave, taking into account the contexts of the studies, the observed results, and the explicit quantitations of bias that the analysts put forward. And once you have that, you can go on and obtain the value for the quantity that you would use in the cost-effectiveness analysis model. I am describing this at a quite abstract level, but it is concretized, I believe, satisfactorily in the chapter. Going through this conceptualization, we come to several realizations. There are some implications, and there are differences between the evidence synthesis, between the systematic review and meta-analysis that is traditionally used for summarizing evidence, and the system and the meta-analysis, the evidence synthesis that one would do to inform a parameter for a cost-effectiveness analysis. There are differences in the acceptable degree of comprehensiveness, the goals of the evidence synthesis, our willingness to learn across study designs, whether we need to grade the so-called strength of the evidence, what sort of statistical modeling choices we make, and whether in the end we can actually attain objectivity or should we settle for transparency. A bit more descriptive, but again with not so much detail. Evidence synthesis for informing cost-effectiveness analysis. Comprehensiveness is a desired attribute, but it is impractical to demand it as a necessary attribute. A cost-effectiveness analysis model has many parameters. It has tens or sometimes hundreds of parameters, and it is impractical to demand a comprehensive evidence synthesis for all of them. The goal of the evidence synthesis is to describe evidence in the typical systematic review, but to make a specific prediction in the modeled setting here. There are implications of that about the uncertainty around the estimates that is discussed in the chapter. Cross-design synthesis is probably something that we would do more often when informing modeling for cost-effectiveness analysis, and we argue that if the evidence synthesis is conducted, I don't want to say well, but in one particular fashion, as the one that we advocate for the cost-effectiveness analysis, traditional assessments of the strengths of the evidence, like that advocated by the GRADE group, and others, are superfluous because they are already accounted for. Very often for cost-effectiveness analysis, we would need to have more advanced statistical modeling, and because of all the stuff that I talked about, because of the fact that analysts have to quantitate bias, or their opinions about bias, we can no longer talk about objectivity, but we should be emphasizing transparency. Typically, evidence synthesis is described as a series of steps. I diverge from the orthodox description and organize the steps into a pre-analytical phase, analytical phase, and post-analytical phase. In the pre-analytical phase, you assemble a team, you define target questions, identify evidence, extract information. In the analytical phase, you do qualitative analysis, quantitative synthesis. You assess and account for biases, and you assess and account for non-transferability of study estimates. And by non-transferability, we mean lack of generalizability from the setting in which the study was done to the setting that is being modeled. And then we have a post-analytical phase where we obtain predictions. Now, that being said, the recommendations draw on a large number of recommendations that have already been put forward for systematic reviews and meta-analysis that are being modified or qualified based on the conceptualizations that I alluded to already. So, for example, recommendation 2 says that whoever does the evidence synthesis and the modeling should coordinate, which is immediate. The third recommendation talks about important model parameters, and we define importance of model parameters crisply in the text. It has to do with whether a parameter, it has two flavors, whether a parameter is influential on model results, either locally or globally, and whether it is critical to the perceived validity of the model. And you should do an evidence synthesis, we believe, for the important model parameters. An analytical description and critique of the evidence base is also important. We expand in the text about the content of this. Quantitative synthesis or meta-analysis should model the statistical variability of data and allow for between study heterogeneity, which is what we do in general as recommendations for systematic reviews. The important stuff, which packs a lot of things, is the third part that says that it should yield consistent estimates for all model parameters that are informed by the synthesis. I believe Mark alluded to the need to do a network meta-analysis when you have more than one interventions, because otherwise, if you just rely on pairwise comparisons, your model results depend on the model's parameterization, which is, in my book, a bug. And similar things have to be done when, for example, you're estimating transition matrices for discrete time, Markov models, and so on. Bias has to be explained whether and how it was accounted for, and the goal is to obtain bias-corrected estimates. Similarly, for non-transferability or transferability, the goal is to produce estimates that are transferable, that transfer to the CEA setting. And in the context of doing this whole analysis, this whole evidence synthesis, we are advising people to enumerate scenarios for populating sensitivity analysis, either for structure or for parameter values. And this is my last slide, and I will conclude.
So I'm going to be slightly more effusive in my thanks. I would like to thank the panel for contributing to my personal learning project on health economics. It's been really an extraordinary 4 years, and I have learned an extraordinary amount, especially about welfare theory and about doing cost effectiveness in the US healthcare system. I'm going to be presenting today an example. One of the two examples that exists in the book, and this work was done by Ba Pham, so I can't take a lot of personal credit for it, but I will present the results to you. This analysis came out of a project that was sponsored by Health Quality Ontario. Health Quality Ontario was evaluating various models of end-of-life care. And the reason they were doing that is because it's expensive. It consumes about 9% of the Ontario healthcare budget. And we were wrestling with how best to deliver end-of-life care in Ontario. So the question we looked at was, what is the cost effectiveness of home palliative care relative to usual care for end-of-life patients in Ontario? So Home palliative care is a comprehensive bundle of care that is an organized set of interventions delivered by an advanced practice nurse, a palliative care physician, and a social worker as well, and palliative care that's delivered in the home. We conducted a cost-utility analysis. It was done from three perspectives: that of the healthcare payer, because this is what's standard in Ontario, and that's what our funder asked us to do. But we also represented the two healthcare perspectives that are recommended in the book. So that's the health sector and the societal perspective. We looked at patients over the last year of their life, so that's the time horizon we used, and expressed costs in 2014 Canadian dollars. This is kind of a busy slide that represents about 12 health states that we used in the model, and the health states are stratified by the presence or absence of an end-of-life diagnosis. So the sort of dark ones on the right, I don't know if this yeah, it does. So these ones over here represent patients who have a defined end-of-life prognostic label, and the ones over here are those who don't. And we further stratified by residential settings. So we looked at patients who were at home or in nursing homes or in palliative care facilities. And then we also stratified by the presence or absence of acute illness requiring emergency department or inpatient care. We took our data sources from many places. We did 6 systematic reviews to inform our effectiveness parameters. We obtained our estimates of prognosis from administrative data looking at over 250,000 patients who had died in Ontario between the years of 2007 and 2009, and traced their prognosis through these health states. We looked at a variety of costs. The cost of the intervention was about $19 a day, which translated to a cost of about $4,000 over the last year of life for patients who were receiving it. A very large component of time was cost was caregiver time, which ranged between $5,000 and $20,000 per month. And then we also looked at out-of-pocket costs. We estimated the benefits by mainly looking at the impact of the intervention on quality of life. It was not our hypothesis that models of end-of-life care would prolong life, but the idea was that they likely would improve the quality of life. So we took data from a published study looking at utilities and how utilities change towards the end of life. And then we estimated the impact, the marginal impact of our intervention by looking at the effects on disutilities associated with visits to the ER, hospital admissions, and ICU stay. Here's the results of our analysis. And I'm going to focus mainly on the last 2 rows, and these are the results from the healthcare sector and the societal perspective. We estimated that the cumulative costs over the final year of life for patients from the healthcare perspective would be about $50,000. But the effects of the home palliative care intervention were resulted in cost saving with about $2,200 in cost reduction. And those cost savings were achieved largely by preventing patients from requiring as many emergency department visits and hospital visits. You can see that there is a modest benefit on health. If we look at expected QALYs, it's about 0.5996 in the usual care option, and just a little bit more in the home palliative care plus usual care for a marginal gain of about 0.002 QALYs, which translates into about 1 quality adjusted day. Now, if we look, so that analysis was dominant from the healthcare sector perspective, and if we express results in incremental net monetary benefit using $50,000 and $100,000 as 2 cost-effectiveness thresholds, we can see that there is a positive incremental net monetary benefit. And when we run cost-effectiveness acceptability calculations, we can see there's about a 64 and 65% probability that our intervention would be cost-effective. The results are qualitatively similar from a societal perspective in the sense that we also have a dominant strategy. There's also an incremental net monetary benefit, and the probability of this intervention being cost effective is similar at around 60%. What is slightly different is the aggregate costs. So you can see there's about $100,000 here in costs over the last year as opposed to $50,000. And most of those cost differences are associated with unpaid caregiver time and, to a lesser extent, household expenditures. You can see that there's a small difference in the incremental costs here. It's about $2,000 from the healthcare sector perspective and about $1,000 from the societal perspective. And that's because patients who are cared for using this home palliative care model actually spend more time at home and require more time from caregivers. And so the cost savings in terms of reduced hospitalizations are to some extent offset by the increased caregiver burden. Now, I'm not going to go through this in detail. This is the impact inventory. I'm just going to focus on one or two things. And you can see that we've captured most of these conventional benefits in terms of longevity and quality-adjusted life years. What we've also represented in this impacts inventory are things like quality of death and satisfaction with care. And the home care, the palliative care literature is replete with references to how what is important at the end of life is quality of death. And we've got this in the impact inventory. We don't explicitly represent this in the analysis, but this is a way of demonstrating the range of potential outcomes and what is in and what is out of the analysis. And that's all I'm going to say, and I'll leave it for Norman Daniels.
It's a pleasure to be here, and I'm filling in for Dan Brock, who was a member of the second panel, and the bulk of the drafting of the chapter was really his, and he was in on all the discussions, so you're hearing from an outsider from the first panel. What I wanted to do today is, and I may have confused two panels that I was on recently in suggesting that we focus on, we are responsible only for turning in 3 slides. Well, I have the smallest number of slides of anyone today. I kept to the 3-slide limit, but no one else did. Okay. Whoops. That was not really.
That's how you switch it, okay? You press that button to the right.
All right. Thank you. So I wanted to say something about the background of this chapter on ethical issues. So the opening of that chapter talks a little bit about the opportunity cost calculation that was involved. And I've become particularly interested in thinking about opportunity costs since all the work has been done in University of York on the NICE focus on opportunity cost. What I want to emphasize is that I think what one needs in thinking about opportunity cost is a real justification for taking a threshold as an argument. And I'm not satisfied with the version of that comes out of the work in York and in the UK. Because I don't think that there is an adequate justification, and I'll come back to that issue later. The cost effectiveness is about maximizing an objective function, as the chapter says, or I don't remember whether it's chapter 1 or chapter 12 that says that. And the content of that function is what raises ethical concerns, not the maximization itself. In practice, however, only one issue is generally maximized, and that is the health outcome. And it's, I think the chapter is correct in saying that a lot of the ethical issues focus on the contrast between maximizing health and some of the other concerns. And we saw that in the distribution of, in the concerns about the impact statement, and I'll come back to that shortly. What I did in these 2 slides was summarize what I took to be the focus of the discussion in the chapter that Dan Brock drafted. I wanted to talk a little bit about 2 issues in the division between constructing and using CEA that the chapter uses as a framework for dividing cases. One issue that has been discussed a good deal in the literature is whose preferences should we use in evaluating health states. And this is not unconnected to an issue that shows up in the use of the use of CEA, namely the possible discrimination against people with disabilities. So the issue that I wanted to focus on about preferences is the, excuse me, I'm having a little trouble coordinating my computer with the slides that you're seeing. The division that the chapter cites in this is that the preferences that should be used are the community-rated preferences, the preferences that a community would express, which include some people simply anticipating having a condition, rather than only focusing on the ex post version, which would be people with a lot of experience of a particular condition. So one of the reasons for worrying about whose preferences should be used is the concern about response shift, largely adaptation that is shown by some people who have had long exposures to some conditions. So what I did in a particular study with which Dan cites is look with my sister and a former student at the treatment of people with brain injuries, which is not a particular case that is often discussed in the literature on adaptation. But I was struck in going to a session that my sister had in which people talked about their disabilities and told what they did to cope with them and manage them and adapt to them. And it struck me that they would have to behave differently from people who could put their disability aside and adapt to sensory or motor deficit in a standard way, because the people with brain injuries had to come to grips with what their difficulties were. And they had to do that very consciously. And that would change the kind of adaptation that they had. So I was, one of my former students did a survey of the literature on adaptation and found that it was pretty fragmentary, and that there really wasn't a very good body of evidence that there was a significant degree of adaptation across all cases, all kinds of cases of disease and health states, only some. And those were the ones that reported and became the mantra around which people cited the effect of adaptation. So, although I agree with the finding that we should use a community view, I don't think that the issue should be based on and I also agree with Dan's claim in this chapter that it's a perspectival difference between people who have had a lot of experience, and no one is making a mistake in judging this. I am concerned that the subset of people who show an adaptation response are being treated as if they are the whole case. I wanted to say a little something about the costs and benefits. What the chapter focuses on is that not all the costs, indirect costs and benefits of are counted in traditional CEA, and though the impact statement says that one should identify them and disaggregate them and bring them out. But I think the failure to connect that to a societal perspective suggests a lot of serious thought on the fact that we've got a lot of disagreement among people about how to rank those and weigh those different components that are disaggregated in that way. And it's so the view that I have is that we haven't really addressed that problem about the disaggregation, and that there is an intermediary fudge factor in this chapter, which says if you can't include them in a societal perspective, break them out and list them. And that's really what I see the impact statement coming to. I wanted to shift to a discussion of some of the ethical issues that are raised by the uses of CEA. And here I will basically be discussing a table which you could construct out of the first three bullets. Suppose we take the first question to be about what I elsewhere have referred to as a priority problem. And the other two bullets refer to an aggregation problem and a best outcomes, fair chances problem. And the suggestion I want to make is that traditional cost effectiveness analysis and focused, had a particular answer to how one ought to address those questions. Namely, we don't give any priority to the people who have are worse off, let's say sickest, and that a unit of health effect will be a unit of health effect regardless of how we value it. And if we valued that unit of health effect more for people who are sicker, then we ought to recognize that. And in the so there was a particular view taken by the proponents of CEA rather, in the first three cases. I already mentioned the priority problem. What about the aggregation problem? Anything goes. You could aggregate any unit or any quantity of benefit. And the third one is always go for best chances. best outcomes rather, not fair chances. So cost effectiveness had a particular stand which, in my view, deviated from the valuations that people would put on the answers that one ought to give from a perspective that focused on fairness. So if you focused on fairness, you might say that we would give some priority, not complete and not none, to the patients who were sicker than others. Some aggregations count, but others don't. Exactly which ones is another issue, or an issue that needs to be examined. The best outcomes, fair chances problem, I see as one in which the fairness result says you want to give fair chances to people, and in some cases, regardless of the best outcome, in some cases you would say, unless the gap was too great and you were giving up too much health in the aggregate for a population. So I have a few thoughts that maybe we could come back to when I talk about equity in the discussion about equity weights, which is a nice recommendation from the chapter on the theoretical grounds, but I don't think we know how to do equity weights when there is a lot of interaction effects. And as I have some further thoughts on thresholds, but I started by saying what I thought the main point was, that we don't have adequate justifications for any of the thresholds. Okay, so let me wrap up and
we have time for maybe 5 minutes for questions, if anyone has any burning questions. Anyone? Murray. There movement in the back. We have one.
Hello, Nick Menzies, Harvard University. And given that this is the first question, I haven't given it time for a sort of introspection to work out whether it's actually that useful. But this is a question for Norm, and you raised the point about fairness. And to me, that seems like, are we now thinking about another equality that we could define quantitatively? Or I guess how can we sort of, is there a quantitative way to build that into our analyses? I'm sort of thinking here about, I might, in a sense, talk about, equality of what? And so if it's not equality of kind of, in the way that we define qualities, what are the other equalities that we might be interested in?
I guess I was drawing on my own experience in the classroom with people who were make judgments about, okay, thank you, judgments about fairness. Thank you very much. And I don't have any quantitative background in which to talk about this, aside from that experience in the classroom. So my view is that you might check on the judgments about fairness that people make in settings. My experience is that we don't have a lot of fairness judgments for whole populations, certainly whole societies. And on the other hand, we do have a lot of experience with people around us and convenience samples in classrooms and so on. So I don't have any particular insight to put on what we would judge to be fair, but I do think that there are some judgments about fairness that a lot of people would agree to. And I don't think it's just the people in my classrooms.
Josh?
Josh Cohen, Tufts Medical Center. Maybe, Karen, this is for you. The discussion of probabilistic sensitivity analysis as being like a really great thing, which, and I love it and have used it a lot, versus one-way sensitivity analysis or sensitivity analysis in general. We all know probabilistic sensitivity analysis allows you to get a distribution on the results, allows you to consider multiple assumptions simultaneously. How did the panel consider that benefit against the, I would say, limitations that, number one, the distributions that are necessary to do PSA are, well, a little shaky, maybe not really based on, reality or, I don't know, information in general. And number two, and maybe this is even more important, what was I going to say? It's getting so late. Oh my God. You made me all nervous. Well, answer that one and we'll come back to me. Oh, no, this is it. Got it. Okay. Some of the most important assumptions, like whether a clinical effect will persist after you stop using a medication. Those kinds of assumptions tend not to be amenable to putting distributions on them, so they tend to be left out of PSAs. And so, what's the usefulness of a probabilistic sensitivity analysis that doesn't look at what's really important in terms of sources of uncertainty?
I'll give it a try, and then Mark can chime in if you'd like. So just because it's really hard to do doesn't mean we shouldn't try, I guess would be my kind of flip answer. I think it's to really get at decision uncertainty, this is the tool, is to quantify the uncertainty of our inputs and propagate it through to uncertainty of our outputs so we can get probability of something being cost effective. It also leads into our ability to do expected value of information analysis, which I think some would argue is even more informative than just the PSA. But you can't get an EVI analysis without doing the PSA first. So there's also the other kind of thing about that you get a more accurate expected value if you do the PSA. I'm sure you know that minor argument. So in terms of the structural sensitivity analysis, how do you evaluate these assumptions? Well, you could, in theory, and Tom may have some opinions about this, but you can, in theory, if you have a sense about a very informal distribution about those assumptions, you can actually evaluate your structural assumptions within a PSA. As long as you can quantify it and put a distribution on it, you can throw that into the PSA. And I would argue I can see both sides of the value of doing that versus just doing a scenario analysis or doing both. So you can do it. I think that's an area of the future of really trying to come up with innovative ways to throw in your structural assumptions into the PSA.
Karen, if I may add, and Josh, I think that we have to decouple two concepts. One is the concept of uncertainty propagation, and the other is the concept of a sensitivity analysis. Because you can have a sensitivity analysis that's probabilistic or deterministic, but uncertainty propagation and sensitivity analysis are two different things. That being said, sensitivity analysis is conditional in nature. It's a conditional idea. It says I condition on values of input to see how much that affects the output. Whether it's done probabilistically or not, it's a different story. So I think that the answer to what you are posing is that both of these tools are recommended and are useful. It's just that they're for different things.
Right. In the interest of time.
And move to our next session.
We'll take that off first.
leave it on the chair, yeah. To save as much time as possible. What? Okay. To save as much time as possible for the actual remarks and discussion, could I ask the members of this panel to come up and to stay here during the session so we won't spend any time going back and forth. This is we're running a few minutes late and I don't want to cut into this panel if I can avoid it. This is the panel on cost effectiveness and policy considerations. And the panel members mulled over the question as when we first talked about this, how will the second panel's recommendations encourage or discourage consideration of cost effectiveness analysis? We have 4 panelists, and they'll be speaking in a somewhat different order from the list on the agenda, because we discussed that as well and decided the logic of the subjects fit a different order. The first speaker will be Robert Dubois. He's an MD, PhD, the Chief Science Officer of the National Pharmaceutical Council, a health policy research in Washington, D.C. He's also a general internist, and he's co-founded and led various healthcare research organizations in developing quality research with practical applications. In these introductions, which are very brief, I'm focusing primarily on the groups with which they've had experience that can underlie their comments on cost effectiveness analysis and policy. Lou Garrison is Professor Emeritus at the University of Washington School of Pharmacy. He was Vice President of Health Economics and Strategic Pricing at Roche Pharmaceuticals in Switzerland. He's currently President of ISPOR, and he co-chairs their Special Task Force on U.S. Value Frameworks. Harrell Chesson is a health economist in the Division of Sexually Transmitted Disease Prevention at the Centers for Disease Control and Prevention. He has worked with CDC's Advisory Committee on Immunization Practices on issues related to the cost effectiveness of HPV vaccination. And Mark Hlatky is Professor of Health Research and Policy and Professor of Medicine, cardiovascular medicine in particular, at Stanford. He's worked with the American College of Cardiology and the American Heart Association to develop numerous guidelines and is currently on the Heart Association's Task Force on Practice Guidelines. And to each of you, you have the option of coming up here to make your remarks or of sitting there and making them using the mics that are in the chair. So, Bobby Dubois, please.
I guess I'll sit. So I'd like to take a couple of minutes and walk through sort of 4 policy issues and how they relate to the great work of the group and the dialogue that we've already had. And actually, many of the little ideas and snippets have already come out, and I want to try to package them up. Those 4 areas are justifying a price. I deal with the pharmaceutical industry, so we're healthy recipients of that dialogue and policy issue. Centralizing decisions, should we do that or shouldn't we do that? National budget concerns, and public response to health economic decisions. So 4 different areas. So the first is the price justification one. Throughout the day, people have said the cost effectiveness analysis leaves out some factors. Well, it's an area without any treatments, or there's issues about hope. And yeah, the cost effectiveness analysis may not incorporate that. Just saying it doesn't incorporate it isn't good enough, because people are trying to justify prices based upon it. And if those extra CEA factors are really important, we've got to figure out a way, either qualitatively or quantitatively, to get it into that and have people realize CEA is just a piece of what defines value. So it's not enough just to say, yeah, it doesn't include that, don't worry about it for now. It really has impact, and it has impact on innovation and what does and doesn't get brought to the market in the future. So that's the first issue. Second issue is centralizing the decision. My belief is that one size won't fit all for a model. The book comes out with 2 sizes will fit all. Well, I don't think 2 sizes will fit all. It's not a hypothetical issue. The Part B recommendations are built around determining a reference price based upon a cost effectiveness analysis. If the election had gone a different way, that would have been enshrined in CMS decision making in a big way. 1 size doesn't fit all, 2 sizes doesn't fit all. Even within payers, the longevity of a patient within your environment, maybe 1 year, 2 years, or at Kaiser, 17 years. I think it's 17 years, something like that. So we must be thinking in terms of having many ways to think about cost effectiveness analysis, and again, it's way more than 1 or 2 or 3 different ways. Third area is national budget concerns. We're spending too much on healthcare. It is absolutely appropriate to talk about we're spending too much on healthcare. It's absolutely appropriate to look at the cost effectiveness of an individual technology. What isn't appropriate from my standpoint is to take the number of patients and multiply it by the cost effectiveness, say it's a big number, and say, well, we can't afford that, therefore the price has to fall. If it's cost effective, it's a societal problem to figure out, do we want to pay for it or not? But if you say Sovaldi's really too expensive society, we should spend less on it, then what you're ending up doing is saying we'll spend more on stuff that's less cost effective. So that doesn't make a lot of sense. So the issues we talked about really have policy impact. That's the point I'm trying to get at. And the last is the public response to health economic decisions. You know, we tend to like to stick our head in the sand, death panels, that's a natural thing. Not that this will solve the problem, but we will dig ourselves into a bigger hole as health economists if we don't make our models publicly available. And thank you to Josh Cohen for bringing that issue out on the table. The models, the assumptions, the executable, all has to be in the public domain. Especially if we're going to be making health technology and allocation decisions based upon it. You want to be an academic, you want to publish something you expect nobody ever to use, by all means, keep it hidden. But if you want people to make choices based upon it, it's just wrong. I can't cite an ethical policy, but it's wrong not to have it publicly available. So was there another point I was going to make on that? So it's also the core of scientific advancement. It's all about reproducibility. Transparency is a necessary but not sufficient condition. We need to have transparency of what you did, but if we don't see the equations, we won't really know. And then I will finish with a plea. Brian Luce and I were talking earlier about, like, how do we make this public accepted policy that everybody makes their models available? He says, well, you've got to get some teeth behind it. He suggested the journals. That if the journal editors, just like they did with clinical trials, if you do not register your trial before you start it, New England Journal, JAMA, BMJ are not going to publish it. If you don't make your model available, we're not going to publish it in our journal. So if JAMA would like to raise their hand and say, we will start that new policy, that will make me very, very happy. But this is my new Don Quixote quest to try to get everybody to make it available.
Thank you. It's an honor and a pleasure to be a part of this discussion today. Like the others, I congratulate the second panel for moving the science forward with this volume. But as they've noted, there are things to be done, so we're not done with our work. And I think I'm going to touch on 3 topics of kind of areas that we still need to do some work in. I mean, one of the things is they did note that the first panel also recommended a societal perspective, and in general, maybe only 30% of studies even kind of tried to do it, and you could argue about whether anybody has ever really used the real shadow price of all the resources in an analysis, which was one of the recommendations. But I want to comment on 3 things. First is just say a bit about the proliferation of value frameworks in the U.S. and some work that ISPOR is doing on that. And related to that is the need to expand or broaden the measures in the cost effectiveness analysis beyond the cost per quality. And finally, to touch on, I think, something Bobby touched on, this need to consider the long-term impacts on drug prices, R&D, innovation, and what is this in the related issue of dynamic efficiency. In the last 2 years, as have been mentioned several times, we've had a large number of value frameworks promulgated in the U.S. Motivations for these differ, but in general, their emergence probably reflects just general cost pressures in the system. They differ in terms of the relevant stakeholders, the perspective taken, and what I like to call context. Several of the frameworks, notably American Society of Oncology, Clinical Oncology, focus on the shared decision-making decision between, the interaction between the patient and the clinician. Okay, and what should be discussed, what should be the elements of that discussion. To me, that's a very different context than the cardiologist, and I think Mark will talk about this, saying we should use cost effectiveness, and in fact the cost per quality, when we're developing clinical treatment guidelines, which would then affect that interaction between the physician and the patient. And then at kind of another level above that is the kind of recommendations of ICER, which is the third context, and it's really more aligned with what I think is the healthcare sector perspective that the panel has discussed. And it's really whether a health plan should provide access to a particular technology in its covered health benefit package and at what price, which is basically what we normally call health technology assessment. Now, all of these frameworks, there's some overlap in that they have some sort of indication of clinical benefit or clinical utility. They differ in terms of costs, and they also differ in terms of the stakeholders involved. Now, it is notable that I think between both the cardiologists and ICER listed a cost effectiveness threshold range of 50 to 150,000 per quality. So that was really the first time in the United States that anyone had ever taken a position and said, this is what we're going to use for that. So that was an interesting step forward, step forward. So now, but ICER at the same time, ICER follows the standard methodology, I would say, of the first panel and of NICE and what our field has been recommending for the last 20 years. Do a cost utility analysis, do a budget impact analysis, okay? But they've taken this one step further that Bobby mentioned, which is this affordability adjustment. And I think at this point, that's a real challenge to our field. It's not addressed in this volume. It's not well supported in theory. It's not well supported in practice. Their approach seems very ad hoc. So I think that's an area where we need some work. So it's a challenge to us. Now, it's also important to recognize that this volume, I'm sorry, she gave me 6 minutes, right? So, yeah, okay, so you're giving me signals here. This volume will affect the world, okay? People around, ISPOR has 20,000 members in over 120 countries. So what the information in this volume is a global public good. It will affect behavior around the world. Last Thursday and Friday, I was in Poland. I looked at the third iteration of their guidelines, very well written English translation, pretty much standard, sort of nice way of doing things. The big differences in Poland versus the United States is they actually use these guidelines in decision making in the Ministry of Health. One of our members is the Deputy Minister of Health, and so they're taking how they use this all very seriously, and they're practicing what we preach. Okay. So last spring, ISPOR established an initiative to address some of the concerns around these value frameworks, and I am not going as fast as I thought I would, but Peter and I are the co-chairs of that. The goal is to issue a white paper, a science policy white paper by March of next year, basically laying out appropriate approaches and methods to constructing value frameworks. So we're tackling the issue. We have a stakeholder, we have a special advisory group, and so on. So there's a process you can look on our web. I will say that the task force members have already expressed the view that the cost per quality is likely to remain the core of thinking about cost utility or cost effectiveness analysis in healthcare. But there's a general recognition that we need to add some other considerations. First of all, productivity is one that's been mentioned, equity considerations. We have a long list of things, some of which Bobby mentioned, such as financial risk protection, a value of hope, in real option value. We have a long list of things that have come out in our discussion that we want to consider. And then we're essentially it begins to look a lot like the impact inventory that the second panel has recommended. And then the challenge becomes, how do we incorporate these into aggregating and into reaching a decision? And I would say there are a lot of things still on the table in terms of some modified approaches. The essential approach of the second panel was disaggregate and list. We will try, but suggested, try to aggregate as much as you can. The primary methods are some kind of form of cost-benefit monetization or some sort of MCDA, or just say, this is how far I can get. I'm going to have a deliberative process to deal with the rest of it. So the impact inventory is really has left us a place to begin. And then finally, I just want to say a little bit about this issue of static versus dynamic efficiency. The foundations chapter really focuses on this idea of constrained optimization. We have a budget. We're trying to maximize qualities for the population, okay? But, innovative medicines, I like to emphasize, are unique economic goods. So in a sense, different than doctors and hospitals. We only produce 30 or 40 of them, 30 to 40 a year. They potentially benefit 7 billion people on the planet. So they're global public goods. The information is a global public good. Now, the second panel, like the first panel, talked about the issue of first copy costs, which gets into the whole issue of patent protection and what's the cost of the medicine. How do we think about that in a long-term dynamic efficiency sense in terms of eliciting the optimal rate of innovation? So they said that the market price shouldn't be used, and we heard about the federal supply schedule, but I would just say there's a challenge for us. There's a question, can we even think about a global public good that, in a sense, we're contributing to covering the cost of R&D, and we're asking other people in the world to contribute. So, we're all in this together. So we can't sort of independently say, well, this is what our contribution will be based on our value, because what you contribute will affect my behavior. That's the nature of externalities in a global public good. So we need to think a lot more about, when it comes to these patented protected medicines, how we're going to think about differential pricing around the world and sharing the cost of R&D. So let me stop there. Thank you.
Thanks. I think I'll feel a little safer if there's a podium between me and the members of the second panel, so I'll come up here to. Like everyone else here, I do want to congratulate the second panel on all they've done to move the field forward. I think the textbook that you've developed will be a valuable guide for those of us who do cost-effectiveness analyses for many years to come. However, I do want to point out two important issues that I have from the perspective of an economist who works in public health policy. First is that the recommendations are quite burdensome. This is due in part to the sheer number. There are 111 recommendations. If there's anyone here who hasn't read them all, I encourage you to do so. I can tell you I have not been this captivated by page after page of well-articulated rules and regulations since the last time I read Leviticus. One of my favorite parts of the book is the worked examples. These are very, very helpful, but I think the worked examples help to illustrate how burdensome the recommendations can be. The worked examples each over 6,000 words. So we have to usually work within a 3,000 word constraint, so it just shows how difficult it might be in practice to follow all of these recommendations. One recommendation in particular, I think, deserves special mention is the value of information recommendation to include that. I would argue instead maybe that the value of information, even though it can be very useful in many contexts, when it is useful, it would probably require being a standalone study in itself rather than just being tacked on as a paragraph in a cost-effectiveness study. For example, in the worked example, there is the value of information study that just reports that the value of perfect information would be about $2,700 per patient, or 1.7 billion at the population level. And I would argue that information alone isn't really enough for a decision maker to do anything. As the textbook points out, we would need additional information, like what is it we need more information on? Disease progression rates, quality of life information, and how should we prioritize going about getting this additional information? So the second issue I want to bring up is the expanded societal perspective. And I think the new perspective goes too far in some ways and not far enough in other ways. I think it goes too far in trying to include too many tangential downstream effects. And one example I will give is the issue of sectors outside of health, specifically the criminal justice sector. In Chapter 8 and in the worked example, there's an example given of an intervention to prevent alcohol abuse, which has the added benefit of reducing alcohol-related crime. So under this new expanded perspective, what we are to include is the reduced cost of crime. This includes the cost of the crime itself, damage to property and to health, as well as the prosecution and incarceration of offenders. I would argue there's another way to think about this. Once a crime occurs, it has occurred and there's nothing we can do about it. But the decision to prosecute and incarcerate is based on society's long-standing deliberation between the cost of incarceration and the benefits of incarceration. Levitt's 1996 Quarterly Journal of Economics study showed that at the margin, for the average prisoner, the benefits to society of preventing crime by keeping that prisoner incarcerated actually outweighed the cost of incarceration. So I think you could argue there's a potential logical inconsistency if we say, okay, we need to include the cost of incarceration in this study, but not the benefits of incarceration if we are doing this expanded societal benefit. The second issue is that sometimes the societal perspective does not go far enough. I think when we have premature loss of life, it has a profound effect on that person's spouse, child, parents, siblings, and other loved ones. And we don't account for that in cost effectiveness analyses. And the new recommendations take a step in that direction by looking at caregiver spillover effects. So you can take into account quality of life impacts on someone providing care for a relative with a terminal illness. However, I think this gets in a messy situation because we are recommending that you can include a detriment in quality of life to a mother who's taking care of her dying child, but once her child dies, you can't include a detriment in her quality of life. So when you combine these two assumptions together, you're essentially assuming that the mother is better off when her child dies. And I think that's a bit ghastly, and I think people would not approve of cost-effectiveness studies that used those assumptions. I think that would come across as worse than the death panels. So that's the two main points that I wanted to address. Thank you.
Thank you.
Thank you. I guess I'll contribute to practice variation by sitting down for this. I too am very happy to be here and appreciate the invitation. And I've been involved in producing some of these cost-effectiveness models, but I want to speak from the other side, which is the end user and the journal editor and consumer of this. And I would say, just looking back at the process, I do wonder whether Brian mentioned stakeholders, making sure that the concerns of the people who are going to actually use these things are reflected in producing the recommendations. A lot of this had appealed to me. I mean, I appreciated it, but it seems like this is really nice inside baseball stuff that was involved. And one of the questions is whether anybody wants to watch baseball because it's too boring or hard to understand. And I think the question is, how do you make these things usable to people in the end, and how do we do it? So I want to put on my first hat, which is as an associate editor of one of the major cardiology journals, and I got to tell you that I think that getting effective peer review of these models is terribly hard. It's hard to get good peer review of any article, and it's especially hard to do it for these because they tend to be overly technical, and the expertise is not there. And if you really want to do a thorough peer review, you really need to dive into it. You have to look at all these parameters, maybe 50 parameters. You have to look at whether they're really consistent or not. In other words, it's very hard, as any of us who knows who's had a student come to us with one of these models. Figuring out whether it was done right is very difficult, and I don't think many journals are able to keep on a technical person whose sole job it is to review cost-effectiveness models. So I think that that's a bit of a challenge, which leads me to my second concern, which is just a question about transparency in terms of the results. And I'm thinking about this in terms of saying, I find it sometimes really hard to understand what happened. And I think the main thing would be to say, you'd like to see the results come out in a way that you can play with them in some ways and trust them. And I don't know if that's making the model publicly available or making an interface available so you can really see how the model works. You don't necessarily have to get under the hood, but you have to have a test drive. And is that something that we could say is a desirable thing for a lot of these models, to really see whether we think that they're performing the way we think they ought to perform, even if we don't have to rebuild the model ourselves. Finally, I just want to say something about my experience with the American College of Cardiology and the American Heart Association. They developed a lot of clinical guidelines and get a lot of, I think, justifiable credit for having done those things, where the idea is that you look at certain clinical situations and say, what's the best therapy for that situation? And the organizations have long felt that the elephant in the room was the value and cost part. And the thought was, well, we really ought to make this explicit and try and attach a value statement to many of these recommendations. Is this recommendation really providing high value or not? And to make a long story short, we did go ahead and say we want to try and put this in guidelines, and we had these categories. We said this is a high value, intermediate value, or low value intervention. And then we have now tried to roll this into our first guideline, and I am the guy at the point on this in the panel. And my experience in doing this is that we want all these guidelines extremely evidence-based, which gets back to the question of where do you get the evidence from, and how do you judge the quality of that evidence? And I got to tell you, it's very hard for us to do that, and some help in understanding how to judge what was a credible, good model is there. And I don't think the way for me to judge that is say, well, actually, Julian Sanders did that model, so it must be a good one. It's we need to have a better way to figure out whether it's a high quality, and I don't know if this really is a checklist. It's not really a quality score. It's more of a reporting guideline that you come up with. So I think we need help in trying to judge the quality of it. And the other part is to say that I've got to say that looking at it and trying to attach value statements to specific recommendations, it's been very hard because we get 4 models, none of which give the exact same answer. And it's very, very hard to say, well, which one is the right one, and how can I harmonize these in some way? What's the body of evidence on this particular question? And that, too, has been difficult, and maybe would be easier if we had a way, where I could go in and tweak the parameters of this model and that model and see whether they, in fact, are giving me the same answer. If they're not giving me the same answer, what is that? So I'll just close here saying I do think that one of the things that we need to do is figure out how to make our recommendations, or these recommendations, really useful to people who are out in the trenches trying to make some decisions or apply them clinically or in policy settings. And I think the biggest thing there is making it really accessible and transparent, and not going out over the edge in terms of technical elegance, but making it really simple enough to understand for people to believe in.
Thank you. The panel, sorry. This panel, when we discussed how it was going to be conducted, said that they would like a few minutes to respond to each other before we open it to questions and answers. Would you still like that? And who would like to start? Or shall we just open?
Let's just, I mean, I don't know. I mean, I'm fine to, I mean, it's more like I want to say the things I didn't get to say than to respond to the others of the problem. So I'm not really fair to sort of do that. So maybe we ought to give people a chance to ask questions. I don't know.
So if some of you would come up to the mic and ask them to say the things that they wanted to say but didn't.
Yeah.
There's nobody at the mic, so.
Okay. Well, I mean, I just didn't, I sort of rushed through this part at the end about medicines, okay? And and I've done cost-effectiveness analyses of all kinds of medical technologies and flu vaccines and all kinds. But I do think of medicines as unique, and we had a task force on this 4 years ago that was cited in the volume, trying to grapple with, well, how do we think about these costs in a dynamic sense, given that now the estimate is it's 3.5 billion or something per medicine, reflecting mostly all the failures. Okay, so how do we think about that? How do we deal with that? How do we deal with that in our models? Because the social marginal cost of making the medicine is very low. We know that, and so we're trying to figure out how are we going to pay for the fixed costs and share that. But then, as I'm saying, it's not just a U.S. issue; it becomes a global issue because everybody's involved. And so it is poor. We had a session on differential pricing. I think as having countries pay different amounts. There is evidence of free riding in certain countries, to some extent, paying below what you think their incomes would justify. So I think that's a big challenge to the field, and I would defer to the people. I mean, Otterbein had to write that whole cost chapter. You had about 1,000 things to deal with, but it's a fairly short section on first copy costs, and I don't know how much you all actually debated that on the panel. I mean, you might know how much that was a discussion, but dealing with these medicines as unique economic goods, these innovative medicines that are patent protected for a limited period, it's a challenge for the field. So,
is there anybody at the mics yet? The flip side of that is in economics we have.
No, this is Brian Lewis. Just to add to that is
Okay.
the personalized medicine,
Okay,
where
go
we may
ahead.
have, multiple expensive drugs for very few people, and that whole cost. I mean, it goes right back to your point.
Okay. Doug, you want to say that?
Well, Doug Owens, I was on the panel. Mark, I just wanted to ask, you are involved in both producing models and doing clinical trials. And I'm sympathetic to this idea that you want to make them transparent. However, having done a lot of them, I think it's very hard to make them transparent. And do you think that this problem is worse for models than for clinical trials? And we have much longer history of how to report clinical trials, et cetera. But, is there anything we can learn from the clinical trials world about how to make these things more usable and more transparent?
I do think that, I think one of the issues is you can have a complicated model maybe, but some of it's maybe just exploitation and making sure that people can see how it really works and what really is driving it. I think that's the biggest issue in terms of credibility. Excuse me.
No.
There we go. Maybe that's a little better.
Yeah.
Whoa, it's a lot better.
Sorry. I think some of it is, there are economic outcomes that are done as part of clinical trials, which tend to be a little more transparent, because when you do a clinical trial, it's basically, we did this, we collected that, here's the distribution of outcomes, and here's what happened to people, and you can, you can see that, and maybe that's a little harder to do with the model, but I do think that I don't think it's necessarily impossible to explain to outsiders. I think people just need to work at it a little better, and maybe there's an ways to present it, and I thought I heard before about making more use of modern techniques where you can interact with things and have things posted rather than just the written word might be very helpful here. And I think it would be very useful to explore those kind of ways of making sure that people can fiddle with them a little bit, play with them a little bit to make sure they really believe them and understand them. Because I don't think that, trust me, yes, there's a brand name thing there. I said, well, this is, a good company, they make good stuff, but understanding, a way to play with it and see how it works, I think would be very helpful.
I just want to follow up, maybe ask John. The Annals, I think, has one of the largest experiences publishing and reviewing cost-effectiveness models, and I'm wondering if you guys have anything you'd share about how do you figure out whether you believe them or not, apart from having you, John. There has to be a more, broadly applicable.
I will echo Mark's comments that it remains challenging. The best indication for me is subjecting it to the sensitivity analyses and uncertainty propagation and seeing if the results of that make sense. Oftentimes, in the absence of actually sharing the model, it's the only way I get a sense. And then, there's the other logical inconsistency things. But one of the challenges with sharing models, obviously, is the multiple platforms that these models come in. You'd have to be able to understand a pretty diverse group of languages. I know one of the SysNet models still uses Delphi, which is, old, Pascal.
I'd like to just add a point.
A couple of people have been waiting over here. Could we?
We're going to have
that question went on for a while, so I wonder if we could let them have.
Can I add a point to dialogue?
Real quick.
So there's a real push to have clinical trials data at the patient level publicly available, and these are trials that could cost $100 million. These models don't cost $100 million. So I think if it's good for the goose, it should be good for the gander. And these models, whether it's just the play-with version or it's an executable version, it's hard to make an argument not to make it available.
Bill Padula from Johns Hopkins University. I'm also interested in this whole question about transparency. I think that having open access to these models is very utopian. You have to consider some of the unintended consequences of putting open models out there on the market. I've never taken money for a model that I published. I published them on my own time as an academic because I believe in the value of what information they give. But when I give it to a journal, and the peer reviewers, it's a confidentiality agreement between me and the peer reviewers that they're going to give me honest feedback and do a good job. I'm not putting it out there on the open market because just as one unintended consequence, think of what someone like Martin Shkreli would do with one of these models, seriously, in price gouging and those kinds of issues. So I just want you to think about what is going to happen besides the good of having the openness of these models.
Did you have a question in there, or just wanted to make that comment?
Well, it's a panel discussion, so discuss the point.
Okay.
Yeah.
This person has also been waiting on.
So yeah, I'm not going to ask questions about that. I'm David Kim from Tufts Medical Center. I'm one of the lead authors for one of the work examples. So I think this brought up from the earlier session as well on the analyst burden. So I'd like to provide some my perspective as an analyst to conduct this the analysis based on second panel's recommendation. So to provide a short answer on the analyst burden is yes, there is definitely a lot more burden. I've done CEA analysis based on the prior experience before this work example, but compared to that, it's a lot more work. But from my perspective, because we are the health economists, so I think marginal benefits of doing all this extra work is well exceeded the marginal cost of doing it, because I think it generally improves the overall quality of the CEAs. And if these additional work, the help to move this forward in the right direction and to improve the usability and the credibility of CEA results so that the end users, the final decision makers, can use the CEA result with more confidence, then I think all this additional work and analyst burden eventually going to help us as a society to make a better decision in the resource allocation. And also throughout the work example, you mentioned that there are 6,000 words, and including the technical appendix is 10,000 words, but I really try hard to provide it as much as resources for other analysts so that they can have some useful resources. The work example not perfect, but can be a useful resources to where to find this cost of productivity, cost of future consumption cost, and how I actually translate the adverse effect from treatment into the health-related quality of life, so that the future analysts have not as bad as the analyst burden as I have. So that was my perspective. And to the work example, I think mentioned the value of information, and I think really great point that value of information has standalone separate paper with more detail. The point we included value information in the work example is just to help other people to think about the quantifying those decision uncertainty, which we haven't really explored a lot. So I think it's just good to put we did this to help analysts to decision maker think about how to quantify decision uncertainty. And also, I think last point that you mentioned that if we are including the cost of incarceration, we have to consider benefits of incarceration. So actually in the analysis, that's a really valid point. So we included cost of incarceration, but also we included the benefits of reducing crime. So there is data out there which is available from the work example, but there is psychological benefits of reducing crime as a society, and they actually quantify those values. So we try to incorporate those as the benefits of reducing crime. So I hope this clarified some of the issues. Thank you.
Thank you, David. As he mentioned, he's the first author on it. Go ahead.
Hi, Elena Elkin from Memorial Sloan Kettering Cancer Center. My question's really directed to Lou, but I'm interested in comment from anyone who has a thought on this. You mentioned the proliferation of value frameworks. There are at least 3 now, 2 U.S. and 1 European, specifically to look at value of drugs in oncology. Only one, the ASCO one, includes costs, but not in a systematic way. And you mentioned that that the ASCO one is designed to be used in shared decision making. I can tell you that the assessment form is not designed for a patient to use, and it's hardly designed for the average clinician to use or to apply routinely. I'm wondering, maybe this is a little pie in the sky, but is the publication of this new report, I mean, cost effectiveness analysis is the very first, the most essential way of looking at value for money, which is what all of these value frameworks are purportedly trying to help us get at, particularly in the conversation about high-cost cancer drugs. So is this now an opportunity for us to do more than just standardize methods, update our technology, and influence how we perform these, but to really influence the policy space? Or are we just going to see more and more organizations develop these value frameworks, nobody adopt any of them, and nothing really happen?
Lots of questions in there. I mean, in some sense, the second panel is a value framework, right? It's a value framework for HTA, and that's what the first panel was. And I would say ICER, in some sense, for that decision, that's the context ICER's looking at. What is the price? Should we put it? To me, it's a different part of the healthcare system to say, okay, given the price that's been set for that. When the cardiologists get together or guideline writers get together, they're trying to say, well, what clinical pathway should be available to clinicians and patients? One of the hats we ask clinicians to wear is the stewardship of society's resources. But I would say my intuition would be, I don't want my personal physician, when they're advising me, to be making that. I want them in that interaction, that shared, I don't want them thinking about costs. I want that to be purely clinical. Personally, I think it's an indictment of our healthcare system that people have, for catastrophic illnesses, have costs that are so high that that's driving their treatment. I think it's just like it's a flaw in our healthcare system. So I wouldn't even want that discussion in that ASCO framework myself. That's my personal view. But I think, I think it's the issue of the clinician-patient interaction is really a human factors issue. We have people complaining now that our doctors are sitting at the computer terminal and talking to you and asking you questions. That's human factors. And so it's not something, it would take a study, a controlled trial to sort of say, what's the best way for doctors to interact with patients? So I don't view it as the same question as the value framework about what should we be willing to pay and provide in our insurance packages, which is what ICER's about. In some sense, the second panel is kind of, at the broadest level, societal perspective, that's what we're saying. What should society do? Now, the healthcare sector perspective is saying from the payer's point of view, we're trying to get them to align with what would be good for society. So trying to structure incentives in all of those interactions to line them up. I don't know where our task force is going to come out on that. We may say we're only going to focus on this HTA decision, just like the second panel did, given our expertise. That's what we're most comfortable with. We really encourage the oncologists to explore this interaction with patients. It's very important, but that's more human factors than it is economics, so.
Well, and if anybody's interested, we did a side-by-side comparison of 4 different frameworks, evaluation of the same therapy, and the punchline is that they came up with very, very different answers for a whole host of reasons. But I think it takes your point to the sort of the empiric level that these approaches are very different, and is one better than the other? That's, I think, what we have to wrestle with.
I wanted to add one thing, because Sloan Kettering has the novelty factor in there, okay? One of the things as an economist, you're always challenged, well, you talk about innovation, define innovation for me. So, my first inclination is an operational definition. If it gives me qualities or it saves me money, cost offsets, it's innovative. It's just operational, nothing about the science, the sexiness of the science. But I think in recent discussions, there's sort of a spillover effect, a scientific spillover effect, so that if a company is working on a medicine and the trial fails, then everybody else who's working in that disease space now knows more about the science in that area. And if we just pay for the quality then we're not subsidizing failures enough from which we all learn, or successes. So some of the stuff we've written, we call that scientific spillovers. And it really is about the sexiness of the science. It's not just about increasing quality. So when we think that's a kind of a factor we might want to consider in adding to value. But again, the core of it, for most of what we're talking about, is the quality gain and the cost offset. We're talking about, as Bobby was saying, if we leave other things out, are we distorting our decisions? Do we need to bring those in? Yeah.
Last question.
Yeah, Eric Dasbach, Merck. Just like to revisit the issue of transparency, model sharing, and reproducibility. One of the questions I had just in this area is what outreach had been done in terms of just looking at other industries, specifically the tech sector, the software engineering industry. They've looked at these issues of transparency for many years.
Could you speak to the mic a bit better? I don't think people
sure.
can hear
Yeah.
you in back.
So I guess what I'm proposing is, and asking actually the question, is what outreach has been done in terms of looking at other industries as it relates to looking at transparency. For example, if we look at in software engineering, one of the things that they put into place are what we call test suites. All right, that's not something we really formalize in our field within our models. We try to do it with sensitivity analyses and so forth. But as we think about putting together model development plans, one of the things we can do is put forth these test suites. These test suites are a quick way of actually looking through what's going on with the model, much like we do with the sensitivity analysis. So that's one potential way out of the box in terms of transparency, is starting to formalize and think about testing. The other is, and I don't know how much this was discussed, was just utilizing open source platforms. So we're beginning to see, for example, on GitHub and others, other sort of social coding sites, new packages put out like HEMOD and so forth, which allow others to contribute to the development of these models. As others, for example, anyone within this room contribute to this, I think we have a level of transparency and comfort with this, along with the test suite in there, that would go a long way in terms of answering these issues of trust and reproducibility. So the question is, were there any discussions or conversations just on test suites and open source software?
That would have been in modeling discussions, and Karen's shaking her head. I don't think there were.
Can I make a comment?
Sure.
You know, I would make a distinction between having a model that's transparent and can be understood versus saying I'm just going to put the whole, you know, all the source things out there that anybody can use it, which I think are two different things. I mean, I think that I'm arguing you might get more from putting it all out, but I think you can be much more transparent without necessarily saying, you know, here it is, you know, you can try it yourself at home. You know, I think that that's a challenge with that, and there may be ways to standardize certain sensitivity analyses or other things, or show your results in the following way, or allow people to interact with the model in a certain way to really understand how it's working.
So that actually is the function of the test suite, is to actually lay out for people, this is how I think this model should be performing at each of these steps. And that provides sort of that transparency and understanding as we walk through the model, rather than getting it and trying to figure out, where do I start?
I think we're ready for the break. When do you want people to come back?